Hello, greetings. This is Bob Gooney again. And again, I'm the director of the Scottsdale Neurofeedback Institute and the ADD Clinic. And we've been doing brain map-based neurofeedback for 28 years. We use multiple databases in our assessments and treatment planning. And people ask, why do you use so many? So I want to answer that question. There's many databases out there. And there's, depending on how you count, we do 4 or 6 databases. First 2 were developed at Harvard Medical School by Frank Duffy and his crew, and by Roy John and his team at the Brain Research Labs at New York University Medical School. So everything has kind of come after those 2. Those are foundational. Unfortunately, Harvard didn't put theirs up for sale. They kept theirs for their own proprietary use. But NYU quickly put theirs up to sale, and was used all over the world. And was the foundation for an awful lot of research. And we've used it and NeuroGuide from the very beginning. So why do we use so many? It's that each one has different windows where we can see different things in the brain that other databases don't give us those opportunities. So we're going to kind of go through them and talk about the pros and cons. So first one developed that we use is the New York University Medical School database. Again, developed by Roy John and his team at the Brain Research Labs. So Leslie Pritchett and Robert Chabot and others on that team are kind of world leaders in it. And then they not only developed the database, they did tons of research. So one advantage of the NYU or Roy John or NXLink, that goes by different names, database is we can compare apples with apples, because a lot of the early research was done with that database and still is today. So let's give you a little more information about it. It's ages 6 to 90. You always have to look at what ages. And the NYU database goes from age 6 to 90. And there were 782 subjects in it. And they went through extensive evaluation to determine that they're normal. So the 782 people were screened to be normal through testing and interviews and rating scales and observation. If they had any doubts, then throw them out was one of the principles. So it's been tested over and over again. Not only have they run more normals through it from New York, where they established it, but last I heard, 38 countries had run normals through the NYU database. And every age bracket, every time, is what I was told, came out spot on normal. So it's really been well researched, and we know it's accurate and predictable. And we're going to show you what that looks like. Let me see. That's not it. There it is. So here's the NYU data, 11 pages of statistical data. And the maps are essentially color graphs based on standard deviations. So this bell-shaped curve of standard deviations, z-scores, goes from normal to the worst 3 out of 1,000, 3 standard deviations. Now, it comes with 11 pages of statistical tables, and those go far beyond 3 standard deviations. So at times, this is all white, one of them is, and we look inside, and maybe it's 4 or 5 or 6 standard deviations. So this gives us absolute power, relative power, asymmetry, and then on the bottom, coherence. And it's side-to-side coherence. Is T3 and T4, are they sharing activity in a way they should, or sharing too much or too little? And the asymmetry isn't front to back, it's side to side. So we're looking at, there's more power over here, let's say, on F7, F3, C3, etc., than on the right. And up here we can see that. We can see there's much more highly elevated beta on the left than the right. So we can see that in the asymmetry maps. And then internally, we also have data on other issues. One of the big ones is discriminant scores. So inside we have discriminant scores for a number of different disorders, for children, ADD, and learning disabilities. And this is the only database I know of offhand that has a discriminant for ADD. And then for adults, we have about 10. So we have major depression, and it breaks it into bipolar and unipolar. We have dementia. We have post-concussion syndrome, and other things. And this is the only database that has some of those that I'm aware of. So it's very valuable to have the NYU database for those discriminants. It's not uncommon that it pops up with major depressive disorder and tells us it's the bipolar subtype. And maybe that wasn't obvious in the workups, and maybe it hasn't emerged yet, because it can predict disorders before they become present. So it may say that there's major depression of the bipolar subtype in a 22-year-old, but may not manifest until the 40s or 30s. So those are kind of uniquely valuable pieces of data. We're very, very glad we have access to this database. And with dementia, it may tell us it's vascular dementia. It may tell us it's alcohol related, may tell us it's Alzheimer's. And again, it can predict that 10 or 15 years ahead of time. So that's very, very valuable. And the research has shown it's highly accurate. So a lot of big advantages come with the NYU. Now, there's things it doesn't have. So we're going to look at another database. So I can't see it. Where's the NeuroGuide? Okay, so let's go inside. This has a nice feature where the NeuroGuide was developed by Robert Thatcher, and has 625 subjects, the last I heard, ranging in age from 2 months to 82 years. So it goes lower than the NYU. It stops at NYU starts at 6. This starts at 2 months. So we can do little toddlers and babies even. 625 subjects last I heard. He may have increased that since then. And it includes eyes open and eyes closed. The NYU is only eyes closed. This includes eyes closed and eyes open. And linked ears and Laplacian. We'll talk about Laplacian a little. And Loretta. And it has discriminants for learning disabilities and traumatic brain injury, but not for the emotional and psychiatric disorders. And this is a table which shows what's called a split half reliability test. So it compares different electrodes on split half test retest. And we can see that a lot of these numbers look very, very good. So it's a way of testing the validity and accuracy of the database. And then we also have absolute power and relative power. We have amplitude asymmetry. And this involves front and back, side to side, different angles, whereas the NYU is just comparing left and right. It has coherence. And it has phase. So phase is an additional thing we didn't see with the NYU database. Now we can look at timing, how long it takes signals to get from one place to another, instead of just coherence. So this is going to supplement significantly the kinds of data that we have. But we're missing some things too. And then internally, we're going to see that there's 1 Hertz bins for absolute power and relative power. So now we can look at 1 Hertz all the way to 30 Hertz. And by the way, the NYU goes from 2.5 to 25 Hertz. This one goes from 1 Hertz to 30 Hertz. So it's a wider range. So we can see, for instance, here that 26 to 30, which it wouldn't be included in the NYU, is actually worse than areas a little slower. So the very fast beta is worse than the 21 to 25. We would have missed that. So we need to supplement this with what we're seeing from the NYU. But we wouldn't want to miss out on what the NYU database gives us. And then this has eyes open and eyes closed. And it has Laplacian as well as linked ears. So what's the advantage of Laplacian? Well, Laplacian is going to give us information where we can see what's going on without linked ear contamination. With linked ears, everything's compared to the ears. So if there's something very large at the ears, everything gets compared to that, and we'll have what's called linked ear contamination. It'll make it look much more diffuse, and it'll show elevations of whatever's abnormal being picked up by the ears all over the brain, perhaps, or in various areas. So Laplacian is an excellent way to control for that. So this is going to be Laplacian. And we could see before that the beta was all over. And now we can see there's areas where it's not as strongly elevated as other areas. And sometimes when you switch to Laplacian, it cuts it back dramatically. So this can influence diagnostic decisions and treatment planning. We may not need to be training all over the brain. There may be a reduced number of areas that are critical. And so we're not going to waste time training areas where elevations aren't actually there. We'll be able to nail down. Now, sometimes linked ears is more accurate and correlates more tightly with symptoms, but most of the time the Laplacian does. And research by I.A. Cook and Andrew Luchter at UCLA that compared Laplacian with linked ears showed that the Laplacian was overall superior. So, and then we have discriminants for learning disabilities for children and for traumatic brain injuries. And I'm going to try to go back to that. It's working very well. We have to go to linked ears. Eyes, there we go. So here's the traumatic brain injury discriminant analysis within the Thatcher database. In this case, it's negative, and it says not significant. But sometimes it says 99.5% match with 650 VA head trauma rehab patients. And then down below, and we don't have it here, but down below it would tell us the rating of probability for severity. So it would have a statistical number on the level of severity for that individual's head injuries compared to 650 VA head trauma rehab patients. So this can give us supplementary data. And this gives us percentages all the way down to 55%. The NYU discriminants start at 90%. So if it's 89%, it tells you negative. If it's 90% or above match with their sample of people with that problem, then it's a positive. So here, if it's 88%, it would tell you, yes, they're a match at the 88% probability level. And we found this to be much more accurate than the NYU post-concussion syndrome discriminant. We find that this is much more accurate in correlating with patient history and how we can see head injuries in many other ways in the maps. Okay, so we're going to go on, but I can't. It covers what I'm looking for. I know. So with the Thatcher database, NeuroGuide, we have eyes open, eyes closed, linked ears, Laplacian. We have discriminants for learning disabilities for children and head injuries from age 13 and up with the traumatic brain injury discriminant. Now, this is, we're going to look at the NeuroRep that was developed by Dr. William Hudspeth. And it's eyes open and it's eyes closed. And there's, last I heard, 85 subjects, so it's fairly small compared to the 782 in NYU and 625 members in the NeuroGuide. So this is a small sample between the ages of 18 and 59. We started with Air Force pilots, I believe, from Vanguard Air Force Base. So it's mainly people in their 20s. So that's a big limitation. The others have much wider range, much larger numbers. This kind of just has one age bracket rather than 10 to 12 age brackets. So that's a big drawback. Also, it tends to exaggerate what's going on in the 1 to 4 hertz area. So almost everyone ends up with elevations at 1 to 3 hertz. There was some kind of amplifier problem. At any rate, it was something that you couldn't fix after the fact. So we kind of have to ignore the delta range. But otherwise, it's proven to be a good match with the other database. And this also goes to 30 hertz. Now, this has a unique feature the others don't. The others in the maps stop at 3 standard deviations. It's hard to see, but this goes to 5 standard deviations. So we can look up in the tables how high the others go. But here we can see sometimes there's yellow, which would be 5 standard deviations. And we might miss that in the tables, but here it's plain to see, and we'll pick it up quickly. So there's some advantages with this in being a much wider range. And then we have something that none of the others have. It's really valuable. The others give us mean frequency or peak frequency in the bands. So we can look up what's the alpha peak frequency. Should be 10 for an adult. But what if it's 7 or 8? That would be very significant. But it doesn't have a way of looking at everything. So this has a map that shows us from 0 to 30. And there's white dots for electrode sites, but there's orange dots for every one of those white dots. And the orange dots he calls joules. And the joules are telling us what's the dominant frequency at that location. So all these joules should be at 10 brainwaves per second for an adult. This is an adult. But some of these are down at 2 hertz. Now, that could just be eye movement, but there's joules in the back and over the center. So that could be an issue that correlates with head injuries or other things. But then we've also got joules up at 24 hertz, 25 hertz, 26 hertz. The joules should all be at 10. The posterior dominant rhythm, the rhythm for the brain should be 10 cycles per second. So we see many where all the joules, the orange dots are at 10 hertz like they're supposed to be. But we see people that have suffered different kinds of problems, Lyme disease, hypoxia, head injuries, where they're down in the 5, 6, 7, 8 hertz range for an adult, which would be very, very slow, more like a 7-year-old perhaps. So that can tell us a lot that they're slowing. Now, the normal frequency for the brain in the beta range, 13 to 32 is what I've looked at, is 15 to 16 hertz. But we have people where it's up in the 20s. So that would be a sign of almost always severe anxiety and sleep problems, and perhaps alcohol or drugs or other CNS depressants. Maybe there are benzodiazepines to compensate for the elevated beta and fast beta. So nothing else kind of gives us this exact type of information, where it's looking at 0 to 30 and telling us where the dominant frequencies are, the dominant power. And that does that for eyes open and eyes closed. Now, another thing that's unique about this, we'll skip ahead a little here, and gives us coherence, and it gives us connectivity maps based on multivariate coherence. So this is something that Hatch-Pigott developed, and I'm not familiar with any other database having it. But research has shown that multivariate coherence is much more accurate than binary coherence that other databases use. So Robert Coben has taken this and developed not just diagnostic, but also treatment strategies using multivariate coherence compared with power training, and done research and gotten very, very excellent results with autism and other disorders. So we can look at these maps and see where there's disconnection. Now, it's not based on database. It's just based on the coherence between these different areas. So this is what it should look like with what's called neuroelectric images. And notice these three, let's say, are very tight together. But when we look at some of the other bands, there's alpha. Instead of this area being fairly tight together, we have very long lines, which would mean disconnection. And we could train that back to normal. Also, his research has found that that's very much a depression network pattern. And that when he trains the alpha down and this multivariate coherence back in where it's supposed to be, he sees very quick and dramatic improvements with major depression. And over here, they're touching way too tightly. So there's overconnectivity here and disconnection over here. And this can help in looking at head injuries and other kinds of things. And we found it to be very, very accurate and correlate tightly with symptoms. And we use it for treatment, multivariate coherence for treatment, and see a dramatic results. But not everything works for everyone. So it's nice to have lots of tools in your toolbox. So again, this was 85 people from 18 to 59. Now, we still run older and younger through this because we've got multivariate coherence and we've got the joules, which give us information on dominant frequency. So even when we can't use the database information of coherence and power, we still have lots of other tools in this database that are useful. Now, we have one more that we're going to look at. And again, this is eyes open and eyes closed. So somewhere up there. Okay, so this is NeuroGuide. Okay, now, NeuroGuide has Loretta and individual maps from 1 to 30. But it's only absolute power. It's all ages, eyes open and eyes closed, but only absolute power. And we found that in the research I'm doing that about 50% of the time, it's inaccurate because absolute power is not correlated with relative power. Thickness of skull, density of the skull, thickness of skin and other tissues between the cortex and where we're putting electrodes can be hugely variable. And the skull can be quite thin where everything is very, very elevated. Or the skull and thin skin and other tissues can be very thick. I had one patient that was out playing tennis 4 hours a day, never wore a hat. We couldn't get normal impedances. His skin was so thick and tough. So relative power kind of standardizes for the thickness of the skull. So for instance, we know that 60% of the power with eyes closed is at O1 and O2. For adults, we've seen that over and over, 60% of the power. So if 10 microvolts is what we see, and it's 60%, it's normal. If it's 200 microvolts and it's 60% at O1, O2, and alpha, it's normal. So we can look at relative power and get, we found a much more accurate picture of what's normal and what's abnormal. Often we'll look at absolute power and everything is extremely low or extremely high or just off. And it just doesn't correlate with the clinical data and the symptoms that we're concerned about. But we find that relative power almost always correlates. And the same with Loretta. So we'll have maps where the Thatcher NeuroGuide says all of these are blue, meaning everything's low. But then we look at Eureka Loretta, which is relative power, and we see that it's actually elevated. And that correlates with other data, like the Laplacian relative power, and with symptoms. So we found this is much, much more helpful in making decisions, clinical decisions about diagnosis and about treatment. Now, we don't have a way of training relative power in Z-scores with Loretta, but we can, if we know what part of, let's say, the cingulate's abnormal and what part of, let's say, beta is abnormal, we can put in and do non-database training and train those Brodmann areas or those parts of the cingulate in that frequency range. And we find that that works very, very well. When we wouldn't have had an alternative of treating it with T-score training anyway, because everything was distortedly large or small using absolute power. So this has been a wonderful tool. Unfortunately, it's only eyes closed, which is a big drawback because we can't see what's going on with eyes open. And it's got 84 subjects. So again, much smaller than we'd like. And the age range is only 18 to 35. So it's a very narrow age range, which is a big handicap. But there isn't as much variation, let's say, between 35 and 55 or 65 as there is at other age ranges, like below 18. So that often we can use it for people outside the age range above it and still get pretty accurate data because the brain doesn't change that much. And I was thinking today while I was hiking, if we asked, a 75 or 80-year-old, would they rather we match their brain to what's normal for 75 to 80-year-olds, or would we rather match it to what's normal for 35-year-olds? And I'll bet almost everyone would say, let's match it to 35. So that's a reasonable approach. Dr. Thomas Badinsky did that in Florida with the age brightening program, worked with people in their 70s, 80s and above, and trained their brains to look like people much, much younger. And they made huge improvements. So we may not want to train an 80-year-old to look like what's normal for an 80-year-old. Might be better to use 35-year-old data, or with NeuroRep, it goes up to 59. So that's not necessarily as big a drawback as it sounds. It actually has some beneficial uses. So those are the databases we use. The NYU for eyes closed, it has discriminants that are invaluable, and it correlates with early research. You can compare apples with apples. We love the NeuroGuide, eyes open, eyes closed, up to 30 hertz, and the Laplacian, and a very accurate TBI discriminant. We like the NeuroRep for the jewels and the connectivity maps, and we love the Eureka Loretta. By the way, I forgot to mention, the Eureka Loretta was developed by Roberto Marquis Pascual, who invented Loretta. And he worked with a small team of Joe Lubar, Marco Congedo, and Leslie Sherlin. He chose relative power. So the individual that invented Loretta, Roberto Marquis Pascual, chose relative power, not absolute power. There are those that argue you have to use absolute power. Well, the fellow that invented it said, no, let's use relative power. Apparently he knew the strengths and advantages of relative power over absolute. Now, there's many other databases. There's the Sturman-Kaiser database. There's HBI, developed by Yuri Roptoff. There's QEEG Pro out of the Netherlands. Jewel that John Demos developed, and others. And I own them all. But we found that this is, for our purposes, sufficient and gives us the data that we need. And we'd sorely miss any one of those pieces because they've just all proven to be so useful. And the redundancy is good. When we're going over maps and patients see the same patterns in different databases, it makes it convincing. Different databases are showing the same thing. And Dr. Thomas Kalura did a study comparing, I forgot it was 3 or 4 databases, and they were remarkably similar. So a well-done database is going to be very consistent with other well-done databases. So we'll talk more at other points about databases and positives and negatives, but there's a quick overview. And thank you for your time and attention.